Hello, and welcome to Talking About Tumors with Ryan and Ryan. I'm Ryan Holstead.
And I'm Ryan Quinn. And today we're going to be talking about metastatic pancreatic cancer. This episode's 1 week late to get released because we spent the last weekend in Chicago for ASCO, which we highly recommend to any fellows or anyone interested in oncology.
Yeah, it was a good experience. We're hoping to incorporate some of the new developments into our future talks. Unfortunately for the one at hand, there has not been anything radically different in the metastatic pancreatic cancer arena.
But yeah, definitely a good experience. We love Chicago, we love deep dish, and definitely a good time. Felt like information overload.
All right, so we're going to move into our next tumor site, and this one's going to be pancreatic cancer. As with gastric cancer, as with upcoming cholangiocarcinoma, these are challenging diseases to treat. And although pancreatic cancer is a relatively uncommon disease, it is a high proportion of cancer-related mortality in the United States. I think it used to be the fourth most common cause of death per capita in the U.S. However, when we were looking at the most recent American Cancer Society statistics, it has moved into third, with breast cancer now moving down to fourth leading cause of death, possibly due to increasing rates of this disease within the U.S. And hopefully also due to improving outcomes in patients with breast cancer.
Yeah, definitely one of the more difficult diseases to treat. So we're going to be talking about metastatic disease, which is pretty relevant because only about 15 to 20% of patients are actually considered resectable or surgical candidates at the time of presentation with pancreatic cancer. So the majority of patients that you'll see will have metastatic disease. And the outcomes are pretty poor. Even for patients with a complete resection, the 5-year overall survival rate is pretty low, less than 30% and less than 10% if they're node positive. For metastatic disease, the prognosis is even worse. The 5-year overall survival is about 3% median 1-year survival. So definitely difficult discussions to have up front when your patients are first diagnosed.
Yeah, I find the discussions in general for some of these very challenging diseases, it's something where it's very important upfront to kind of lay out what the expectations are, partially because you do not want to give people false hope. And also, it's not something you want to, after 6 months of treating someone, say, oh, by the way, this is what we're kind of expecting here. Often challenging discussions, especially in pancreatic cancer as well as gastric cancer, because many patients are not candidates for treatment at the time of their first assessment. And I think there's an art to be able to present the data, but still also provide some hope, especially for patients who can derive benefit from chemotherapy, because you want to be maximizing their quality of life, and giving nothing but doom and gloom doesn't necessarily provide that either. So it's always a balance of giving realistic expectations as well as trying to maximize the presentation to show what we hope to achieve with our treatments.
So the majority of pancreatic cancers are adenocarcinomas, so about 85%. There are some other subtypes such as neuroendocrine tumors, which we'll get to in later episodes. So today we're really going to be focusing on adenocarcinoma, which is the most common. Like most other cancers, the incidence is more common as we get older, so it's pretty rare in patients younger than 45.
There's multiple suspected environmental factors. Although the strength of these links are somewhat weak, there is thought to be a role of smoking in the development of pancreatic cancer, history of pancreatitis, both acute and chronic. Diabetes is associated both as a result of pancreatic cancer due to inflammation within the pancreas due to the localized tumor, as well as a potential cause of pancreatic cancer. And roughly about 1/4 of people with pancreatic cancer have had diabetes diagnosed within a few years prior, and 1 in 100 adults diagnosed with diabetes will have pancreatic cancer diagnosed within 3 years. There's a number of ongoing NCI trials looking to see if there's a screening protocol that can catch some of these patients with adult onset diabetes to try to track who is at risk for pancreatic cancer and who isn't. And these are still ongoing at this time.
Also IPMNs, which can be found instantly on imaging, which are intraductal pancreatic mucinous neoplasms, can also be a risk factor, which is why these patients require imaging surveillance to make sure that they're not developing pancreatic cancer.
But we'll definitely cover IPMNs, neuroendocrine tumors, and the other potential pancreatic masses when we go into the localized lecture next.
It's thought that up to 20% of patients diagnosed with new pancreatic cancer could have germline mutations. So the ASCO actually changed the recommendation that everybody with newly diagnosed pancreatic cancer should have genetic counseling and genetic testing.
I'll be honest, hasn't been my experience or practice. We'll get into, there's definitely a role of checking for BRCA mutations in these patients. Certainly if someone has a family history of other malignancies, it certainly warrants a genetic evaluation. I'm not sure exactly what the yield would be for someone who's BRCA negative and what the benefit to them or their family would be to start searching for other genetic tests, but it is certainly in the ASCO recommendations.
Yeah, so things like BRCA1 and 2 can be seen in about 5% of patients. Lynch syndrome can also be seen with pancreatic cancer and a few other inherited genetic syndromes.
We've talked about Lynch before with our MSI high and low tumors, both in gastric and colon cancer. This is the exact same Lynch here. I think this is our first time bringing up the BRCA mutation, if that's right.
Yeah, I think so.
Yeah. So this is, we're going to hear about this a lot more in our breast cancer lectures, but as many of you probably know, there is a BRCA1 and 2 mutation. These are mutations associated with development of cancer. BRCA1 is the one that's most closely associated with breast and ovarian cancer, with rates of incidence up to 70% in patients. Although BRCA2 still provides a high risk of both breast and ovarian cancer, the rates of these are lower compared to the BRCA1 mutation. However, risks of pancreatic cancer are on the higher end. Briefly, BRCA plays a role in homologous recombination, so when mutations occur in DNA leading to a double-strand break, the genes encoded by the BRCA mutation help repair these breaks. Often the mutation is inherited as a single defective gene, but at some point, due to acquired mutations that happen through the course of life, a secondary mutation, such as in another BRCA gene, or one of these other DNA repair genes, such as ATM or PALB2, may arise, leading to tumorigenesis.
Partly for BRCA2, there's no role yet for screening for pancreatic cancer, although there are clinical trials looking at this, and some specialized centers do have dedicated screening programs.
So we'll be discussing the challenges in having effective systemic therapy for this disease. And one of the thoughts are due to just the microenvironment that surrounds these tumors. The majority of pancreatic cancers do arise in the pancreatic head, and these are mucin-secreting adenocarcinomas. And essentially they secrete these mucinous gel that surrounds them that leads to inflammation, eventually fibrosis and the formation of a stromal network. Often when you look at the histology of these tumors, you'll see this dense stromal network and nest that surrounds the adenocarcinoma itself. There's thought that this prevents, good drug penetrance, and there's also very low numbers of lymphocytes within these biopsies. And there's been a term quoted as an immune desert. With the exception of MSI high tumors or tumors with high tumor mutation burden, we have not yet seen a great role of immune therapy in pancreatic cancer. The most common mutations that will arise early on would be a KRAS mutation, but ultimately due to this ongoing inflammation process, numerous mutations happen afterwards, and targeted therapies have had limited benefit due to just the very complex mutational signature of these tumors.
So when thinking about how these patients present, the majority will present with things like severe weight loss, jaundice from biliary obstruction, abdominal pain. Pancreatic head lesions are usually caught earlier than pancreatic tail lesions, simply because they usually result in jaundice. The pancreatic tail lesions tend to present later when they're already metastatic due to other symptoms. But yeah, typically abdominal pain and severe weight loss will be the presenting symptoms.
Pain can be terrible in this disease. The pancreas, as we know, secretes a lot of digestive enzymes. It has a very complex neural network surrounding it, and inflammation can cause severe neuropathic-like pain that often will require very high doses of opiates. And we're lucky to have a palliative care team to help us out these days.
Yeah, I find it interesting. Sometimes they can even do celiac blocks to try to help with the severe neuropathic abdominal pain, which can be helpful.
I've seen utilization of anti-neuropathic medications. Where I trained, fentanyl is a well-liked medication for this because it does have some neuropathic pain analgesic properties.
So getting into diagnosis, once we catch pancreatic cancer on imaging or have a high suspicion, first thing we want to do is get a CT triple phase, which looks at both the arterial and the venous structures. You definitely want to specify to the radiologist that you want a pancreas protocol because they do very thin slices. Because the most important thing is going to be to see if this is something that's resectable, so you need a really good look at the pancreas and the vessels around it. You want to do complete CT, chest, abdomen, pelvis to look for metastatic disease.
Most commonly, the mets will travel to regional lymph nodes, followed by the liver.
The tissue diagnosis is usually done with EUS and ERCP. Sometimes you're only able to get an FNA, which provides kind of a limited sample, but it's still enough to make the diagnosis, although you may not have enough tissue for next generation sequencing.
If you have a liver metastases you can target, that's probably going to be a better yield with a higher amount of tissue available.
And then you also want to check a cancer antigen 19-9, which is the tumor marker for pancreatic cancer, and this can be a poor prognostic factor if it's elevated at diagnosis. And it can be something to monitor as after treatment, although it's not used as a screening tool, only in patients that you already have a diagnosis.
Yeah, it's a sensitive, not specific marker. It's important to know that CA19-9 can rise with anything that causes biliary obstruction. So a pancreatic head causing biliary obstruction, CA19-9 in the 5,000 to 6,000 range or something extreme. You then place a biliary stent and all of a sudden the CA19-9 drops significantly. Maybe in the meanwhile you also initiated systemic therapy and you're like, oh, we've caused a great drop. So it might be more just that you've now cleared out the biliary stent, and it's important to keep that in mind. This is also helpful because if you see it start to rise again, it doesn't necessarily mean that you're having disease progression. You may be just dealing with a stent obstruction as well. So it's important to know that when we get into all of our tumor markers, things that cause other rises that are unrelated to cancer itself. And not all pancreas cancers secrete this tumor marker, so it's only useful in those that are elevated at baseline.
So thinking about staging, for pancreatic cancer, we do use the traditional T and M staging, where T is related to the size, N is the nodes, and M is the metastasis. We're not going to get too much into this because honestly for pancreatic cancer it's not as relevant. Really the more important categories are things like resectable, borderline resectable, locally advanced unresectable, and metastatic disease. We'll get more into what makes this cancer resectable versus borderline versus locally advanced in the next episode where we talk about treatment of localized pancreatic cancer, but those are the kind of more important categories rather than the specific stage. But today we'll just be talking about metastatic disease, which is stage 4. As with most of the GI cancers, unless there's very obvious metastatic disease, this really will be a tumor board discussion with the surgeons and radiation oncologists and radiologists going over the imaging to see if they think that this is something that's resectable or not. So pretty much every new diagnosis, unless again it's very obviously metastatic and not surgically resectable, will be discussed at tumor board.
So assuming that we have a patient presenting with bona fide metastatic or unresectable pancreatic cancer, untreated, this disease has a prognosis measured in months. And this would be in patients who are otherwise fit. And those who are already significantly deconditioned from the disease, prognosis would be in weeks to short months. It wasn't really until the 1990s that we had any effective systemic therapy in this disease. And I don't know what it'd be like to treat this as an oncologist prior to that time. The 5FU regimens that were used in colon cancer and gastric cancer really didn't have any success in pancreatic cancer. In the 1990s, however, there were a series of phase 2 trials using gemcitabine monotherapy, and these did show some efficacy, although they did not increase overall survival and had objective response rates less than 10%. The trials found that using gemcitabine was able to delay symptomatic progression. So basically the time to development of pain or obstructive symptoms related to the cancer. And this was truly one of the first palliative chemo regimens. But as nothing else had worked prior to this, it quickly got adopted into the standard of care. Median survival using gemcitabine was around 6 months.
This actually is one of the first and few drugs that was actually FDA approved just based on this quality of life endpoint. Much kudos, I guess, to the FDA for that. There's a lot of issues now with endpoints in oncology, but this one was really approved based on quality of life. So getting into the basics of gemcitabine, and as with most of our chemotherapy discussions, I really do refer most people to the Oncology podcast because they do an amazing job also at describing
Love Sean Bazar.
Yeah, the subtleties of gemcitabine and the history in a way much more eloquently than I can. But gemcitabine is a nucleoside analog chemotherapy, which means that it gets incorporated into the DNA and will eventually inhibit polymerization. It's pretty well tolerated. The main side effects that we see are cytopenias, particularly thrombocytopenia. You can also get neutropenia. It's given on a 3-week schedule, so 3 weeks in a row with 1 week off. Although in the first trial that was looking at this, it was actually given at first on a 7 of 8 week schedule. So they would get it 7 weeks in a row, then 8 weeks off for the first cycle, and then every 3 out of 4 weeks. Although 7 weeks is pretty toxic and a lot of patients can't handle that. So now we do 3 weeks in a row with 1 week break. And you'll see a lot of patients still have to drop that to 2 weeks in a row, 1 week off, or every other week schedule because of the cytopenias. One of the rare side effects, which again I've only seen once or twice in person, but sometimes can show up when you're reading about this, is that this can cause a TMA, which is a thrombotic microangiopathic hemolytic anemia. So if you have somebody with, unexpected thrombocytopenia and anemia lower than you would normally think, and you see that they have markers of hemolysis, so elevated LDH, low haptoglobin, and look at the smear and see schistocytes, definitely someone that you want to stop the drug and work up for TTP, HUS, because this can be associated with gemcitabine.
More common in patients with renal insufficiency, as this is a renally excreted drug.
Yeah, there also can be hepatotoxicity as well. So it can also cause pulmonary edema. Not very common, but some patients can have flu-like symptoms, which can be frustrating as a fellow because you get calls that they have a fever and then you get all concerned about neutropenic fever, and it could just be a side effect of the gemcitabine. Obviously you want to work up infection and rule that out, but it is a fairly common thing that we see, flu-like symptoms.
Yeah, the myelosuppression certainly are going to be our dose-limiting effect, and you're going to see that in almost every patient. And ultimately, after a number of cycles, that's going to be limiting you from how you can use this drug. Also, another unusual side effect is this pseudocellulitis, which I've seen a couple times, which will be like you'll have either a red foot, a red toe, a red hand, and it's usually about a week or so after administering the drug. It looks almost identical to cellulitis, but might not have that same level of induration as you would usually expect. Both times I certainly gave antibiotics, but it resolves well sooner than I would expect on antibiotics, which made me expect that it's probably more related to the drug itself. Another high-yield point about this drug, not something that necessarily comes up in the day-to-day discussion, but I can see why maybe at the infusion suite they would discuss this, and you do not prolong the infusion of gemcitabine. So the longer you infuse the drug, the higher the short-term toxicities are. So, if you're concerned about some sort of infusion reaction, which is relatively uncommon with this, you would pre-treat and still give it at the normal rate.
Yeah, that's a good point.
So gemcitabine was incorporated as the standard of care, and although the benefits were limited, it wasn't until 2011 that we were able to find a combination of drugs that was able to show superiority. And this was a combination of, like in our colon cancer setting, 5-FU, irinotecan, and oxaliplatin. In pancreatic cancer, this is down to FOLFIRINOX compared to the FOLFOXIRI that we use in colon cancer. Slightly in the modern way that we use FOLFIRINOX, which we call modified FOLFIRINOX, there are some differences. We use a lower irinotecan dose, and we've effectively omitted the bolus for the most part in order to limit toxicity and continue with efficacy of this drug. So if you remember, the bolus of 5-FU is the one that causes the myelosuppression. Just as an aside, I don't know if we talked about this previously, but when you dose reduce or omit 5-FU, you should be dose reducing or omitting your leucovorin as well. The whole purpose of leucovorin is to increase the efficacy of the 5-FU bolus. So if you're not using 5-FU bolus and you're just using infusion, you don't need the leucovorin at all.
So this study, which again was published in 2011 in the New England Journal by Conroy and colleagues, was looking at FOLFIRINOX versus gemcitabine, and it did have an overall survival benefit, which was pretty remarkable at the time, 11.1 months versus 6.8 months. the hazard ratio of 0.57, progression-free survival of 6.4 months versus 3.3 months. One thing to note about the patients on this study is FOLFIRINOX is a pretty toxic regimen and difficult to complete. All patients on this study were ECOG 0 to 1, and they were all less than 75 years old. Something to keep in mind when you're considering this for all of your patients. But this really did establish FOLFIRINOX as a new standard of care for metastatic pancreatic cancer for fitter patients.
In addition to the age and functional status, there's other exclusion criteria which were dubbed significant cardiac disease, chronic diarrhea, history of radiation. These were very fit patients with minimal to no comorbidities, minimal to no symptoms. In general, when we talk about clinical trials, we're always talking about patients who are better than the average person showing up in front of you in the clinic. Important to keep in mind because the number of people who will actually have the opportunity to use FOLFIRINOX in the metastatic setting is unfortunately limited.
Yeah, definitely. I was surprised in my clinic how few patients I was actually able to give FOLFIRINOX to, or patients that I had initially planned to give it to that quickly were very symptomatic and kind of decompensated before able to finish it.
That's a really good point. Pancreatic cancer, lung cancer, these are diseases that if you have a patient that you've been able to confirm the diagnosis, you're looking at them, you see it's metastatic, you really don't want to delay treatment. The person who's coming to you who's a candidate for therapy 2 weeks later may not be anymore. I guess a couple other points on the endpoint for the FOLFIRINOX trial. The objective response rate was about 30%. Which is better than the 10% we've seen in gemcitabine. Most of these patients, by the way, had only about 2 metastatic sites. There was 10% alopecia. Neutropenia was a high rate of toxicity. A lot of vomiting and diarrhea, which we can now improve upon with aggressive symptomatic management. And neuropathy also becomes your dose-limiting issue due to the FOLFOX, due to the oxaliplatin.
FOLFIRINOX was pretty much the standard of care with gemcitabine for less fit patients until 2013 when a study looking at gemcitabine mixed with nab-paclitaxel or gem-Abraxane versus gemcitabine alone. This was a study by Hoff and colleagues in the New England Journal in 2013. And this study looked at about 850 patients who were randomized to either gemcitabine, nab-paclitaxel versus gemcitabine alone in patients with metastatic pancreatic cancer. These patients were a little bit older. The oldest patient on the study was 88 years old. And they did not use the ECOG, they used the KPS, which is the Karnofsky Performance Scale. And this study included patients with a KPS greater than 70.
Which is relatively ECOG 0.
Yes.
Gemcitabine nab-paclitaxel was given on for 3 weeks and went off. And I don't know if we mentioned, but the FOLFIRINOX trial gave only 6 months followed by observation, whereas this regimen was given continuously until disease progression. So albumin-bound paclitaxel or nab-paclitaxel or Abraxane is very similar to the paclitaxel, which we will be discussing in the breast cancer lectures. Thought that the albumin binding can reduce the amount of neuropathy, and probably does, although neuropathy still remains a toxicity of this medication. But for the most part, this combination I find is generally well tolerated, other than the eventual neuropathy and certain myelosuppression that you get from the gemcitabine component. A high yield fact for this regimen is that you want to give the nab-paclitaxel prior to gemcitabine, because there's pharmacokinetic data showing that increases the efficacy of gemcitabine in this regimen.
So the gemcitabine nab-paclitaxel resulted in an overall survival of 8.5 months versus 6.7 months in the gemcitabine alone group. So about a 2-month increase in overall survival. The progression-free survival was 5.5 months versus 3.7 months. The main toxicities were neutropenia, fatigue, and neuropathy in the gemcitabine nab-paclitaxel arm.
Response rates in this regimen was about 23% versus 7%.
So although you really can't do cross-trial comparisons to compare this to FOLFIRINOX, we generally consider FOLFIRINOX first, but if somebody is kind of a borderline performance status, then we would consider them for gemcitabine nab-paclitaxel. In my experience, anyone with like an ECOG of 2 may be more appropriate for gemcitabine nab-paclitaxel rather than FOLFIRINOX.
I think the only time I'm ever reminded to not do a cross-trial comparison is just before cross-trial comparison happens. Like, I remember at ASCO, there's like so many slides where it's like, we don't do cross-trial comparisons, but here's a cross-trial comparison.
Very true. It seems, I feel like when you're first learning, you always want to compare the survivals of different studies, but it's very difficult with different patients and different years.
I think especially
to compare.
Yeah, like as inclusion criteria changes, as palliative care improves. But I after saying that, I do think that it's relevant here because the FOLFIRINOX component, just the benefit was so much better in comparison to gemcitabine within the trial than the improvement from gemcitabine and paclitaxel compared to gemcitabine. So the fact that the control arm did relatively the same, but the interventional arm did better, and all other markers seemed better, I don't know too many providers who would take their most fit patient and choose gem-Braxine over FOLFIRINOX.
Yeah, definitely, I agree.
I think we can be pretty brief on second line in this setting because there really are not really any randomized control trials and really limited data to begin with. I mean, this is unlike other diseases where your targeted mutations might play a role for first-line agents. In pancreatic cancer, they're going to start to have more relevance in second line. If you happen to have a patient who's MSI high, which is relatively uncommon, a high tumor mutation burden, which I think is greater than 10 mutations per megabase in pancreatic cancer.
Yeah, greater than 10.
Or very rarely, like less than 2%, NTRK, NTRK mutation, you may be able to reach for immune therapy for the former two, or entrectinib, or one of the other NTRK inhibitors for the latter. I don't find that these come up very often, and if your patient does not have target mutations, which is the norm, and they initially got FOLFIRINOX, you might be able to use gem-nab-paclitaxel, or you might be using gemcitabine alone. If they initially got gemcitabine-nab-paclitaxel,
could consider FOLFOX. Probably not a candidate for FOLFIRINOX if they weren't upfront.
I think it's really reasonable to consider just symptomatic care, especially if it's an aggressive disease with only a short-term response to your first-line agent. Not many people are candidates for chemotherapy at the time of progression on first-line therapy.
Yeah, definitely. That's a good point.
So earlier we had discussed BRCA mutations in pancreatic cancer, and I mentioned this as a relevant role to our treatment. It's actually a predictive marker, and BRCA mutations tumors with a BRCA mutation are very sensitive to platinum agents. And if we recall, our BRCA codes for our DNA repair protein, and platinum, such as cisplatin and oxaliplatin, intercalate within the DNA. This leads to DNA instability breaks. When the breaks occur, there's now an inability to repair the breaks, leading to increased efficacy, and hence the predictive component of this. The only patients I've seen that have good, long, sustained responses to...
Getting interrupted by a dog.
The only patients I've seen to have good, long, sustained responses to initial chemotherapy, namely FOLFIRINOX due to the oxaliplatin, are BRCA mutants. And these are patients who I have seen have a response. We take a break for a 6 months period. They remain in remission for another 3 or 4 months. The disease slowly starts to grow, and then we're able to retreat and obtain a remission again. I've seen an occasional patient even be able to continue to get responses 3 or 4 years down the road, which is something we do not see in BRCA-negative pancreatic cancer. More recently, there's been a lot of interest to target drugs against this pathway, and the concept of synthetic lethality has arisen, where we try to harness the inability for DNA to repair itself and allow further DNA breaks to accumulate, leading to actual cell apoptosis. And the PARP inhibitors are one of these drugs that have, in animal models, shown an increased rate of cell death in tumors with a BRCA mutation.
Yeah, so the patients with BRCA mutation really rely heavily, since they can't do double-strand repair, they rely on being able to repair single-strand breaks. So synthetic lethality is if you inhibit the ability to repair single-strand breaks, then they keep accumulating, and then once you develop a double-strand break, there's no ability to do homologous recombination, so the cell will die. So it's kind of taking advantage of two mechanisms.
These PARP inhibitors, such as niraparib, olaparib, and rucaparib, have been around for a while in ovarian cancer with success in long-term outcomes, and have had some mixed benefits in breast cancer. And more recently, in 2019, were assessed in pancreatic cancer in the POLO trial.
Yeah, so the POLO trial was an interesting trial, kind of controversial when it first came out. And this was looking at patients only with the BRCA1 or 2 mutation who were initially treated with a platinum-containing chemotherapy regimen. So the goal of this trial was to see if, after patients had response or didn't progress on a platinum regimen, can we take patients off chemotherapy and put them on olaparib maintenance, which is thought to be a little bit less intense, so kind of giving patients a break. So what they did was patients that had received the platinum regimen for 16 weeks without progression, they randomized them to either olaparib, 300 milligrams twice a day, versus placebo as a maintenance.
I think they allowed up to 6 months, so 8 to 12 cycles. No more than 12, but no less than 8.
So looking at the progression-free survival, it was 7.4 months with the olaparib arm versus 3.8 months with the placebo arm. And the overall survival was actually the same, 18.9 months in the olaparib arm versus 18.1 months in the placebo arm.
There was no crossover, which is to say the patients who were randomized to placebo did not eventually receive olaparib.
Yeah, so this trial has been interpreted in different ways. Some people think that this allows you to change to olaparib maintenance if somebody is having a hard time with the chemotherapy after not progressing over a certain period of time. There have also been some criticisms of the trial because you're comparing olaparib maintenance to placebo. So some of the patients that were on chemotherapy and were responding, half of them got randomized to placebo, so were taken off of the chemotherapy.
Yeah, and I'm not sure in clinic how to truly make use of this, because yes, some patients start to get run down from FOLFIRINOX, absolutely. And you can, once you get to 6 months, many patients it's difficult to keep going. Some you can, and certainly if someone's tolerating the drug and not having side effects, I think they're going to get a better long-term benefit from getting the chemotherapy rather than the olaparib. Now, one argument is taking a break from chemotherapy and starting this pill, delaying time to progression might improve quality of life, which is reasonable. However, olaparib is not necessarily a walk in the park. In this trial, there was a 40% number of grade 3 toxicities on the drug, primarily being anorexia, fatigue, and nausea. And you'll see people that you do use PARP inhibitors on, you're going to be starting on ondansetron, maybe even empirically, to try to manage that nausea. And it's important to keep in mind that although FOLFIRINOX is an incredibly toxic regimen, it's a cyclic drug, so you get sick for a few days, then recover for a week, ideally with a good quality of life, and you get sick for a few days and recover, whereas the olaparib, you're feeling unwell every single day that you take the pill. And I think it's worth having the discussion with the patient, but I'm not sure if patients, I have a good response, especially if they're BRCA positive, where they might have a sustained progression-free survival. In this trial, it was 4 months on placebo alone, where you may be able to just use no drugs at all, give them a true holiday from treatment from the medical clinic before restarting on chemotherapy or some other medication when they progress.
Yeah, exactly. I don't really know if this would change my practice, but it's a good trial to be aware of. It was in the plenary session of ASCO. It's something that you'll probably get asked about as a fellow, so good to be aware of it, but I'm not sure if it would change my practice. Beating placebo for a progression-free survival benefit isn't exactly the greatest endpoint. It's not surprising that olaparib beat placebo.
Yeah, survival is unchanged. If our goal is to help people live longer and live better, I'm not convinced that this drug does either of those things. Definitely not as dense of a discussion as our prior conversations, which is just the nature of where metastatic pancreatic cancer is at this time. I mean, there's a lot of interest. There's been a lot of attempts to improve outcomes, and I think there's a lot more to come. Certainly in the localized setting, there's a lot of interest on how to best approach this disease. I think that this is a greatly evolving area right now, and I look forward to having that conversation in 2 weeks.
Yep. Thanks for listening, and please let us know if you have any feedback. You can reach us on email or Twitter.
Bye for now.
For more information, follow us on Twitter at Talking Tumors, or feel free to email us at talkingabouttumors@gmail.com.
Please rate and review the podcast. We really appreciate it.
And special shout out to our friend John Kim for all of his musical talents.
And he is the composer of the music that you're hearing right now. Talking About Tumors is not medical advice.
For medical advice, please contact your own healthcare provider.
Opinions stated on this podcast are by the Ryan who said it and no one else. We have no financial disclosures, and this is done purely on our own time to the sake of our enjoyment of the field of medical oncology.
Thank you for listening, and see you next time.